Hello, and welcome to today's HealthITSecurity.com webcast, sponsored by Imprivata, a blueprint for EPCS success, achieving full DEA compliance while ensuring workflow efficiency. I am Elizabeth Frost, Operations Manager at Xtelligent Media and moderator of today's presentation. We will begin the presentation by our speaker and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of their screen. For all technical matters or difficulties, click the Help icon at the top right-hand corner of the screen. A recording of the webcast will be made available following the presentation. First, I'd like to thank our sponsor, Imprivata. Imprivata establishes trust across the people, devices, applications, data, and clinical workflows, contributing to the delivery of patient care. When this trust is established, providers have the freedom to leverage the technologies and information they need to streamline clinical workflows and deliver efficient, high-quality care in an increasingly decentralized healthcare environment. By offering comprehensive, purpose-built solutions for positive identity, ubiquitous access, and multi-factor authentication, Imprivata is able to establish trust across the healthcare delivery network. Now for today's speaker. Dr. Spencer Ehrman is a VP and Chief Medical Informatics Officer of Hartford Healthcare, a clinically integrated health system in Connecticut. With more than 30 years of experience working in family medicine, he has transitioned his career into clinical informatics with advanced training and certification from OHSU. Dr. Ehrman is now CMIO for the healthcare system, where he works with a talented team serving as the bridge between the clinical and technical components of healthcare delivery. With that, I'd like to hand the floor over to Dr. Ehrman to begin today's presentation.
Thank you, Elizabeth, and greetings all. I'd like to start this presentation with a disclaimer in that I do not work for Imprivata. I do not get any payment from them. I'm doing this because it's a good company to work with. What we're going to talk about today is a little bit about us and Hartford Healthcare, why we went to EPCS, how we went to EPCS, and then the results of how it's all working out. Hartford Healthcare is the largest integrated healthcare system in the state of Connecticut. We have reaches into Massachusetts and Rhode Island. And as you can see by the map, we take over most of the state except the southern half, which is probably Yale and some other hospitals. We have recently acquired our 6th hospital. We have 12 surgical sites, 35 family health centers, over 257 locations all across the state. We are quite a good size. And we are a true integrated system. We are on Epic. We started going on Epic in about 2015, and all of our sites, except the most recently acquired hospital, are on Epic. We average 360 emergency department visits, over 80,000 inpatient transitions to home or continuing care, and 430,000 primary care visits. We touch nearly 15,000 people in our communities every single day. One of the reasons I like to share this information is I bring the opioid crisis to home. You know, everyone hears these huge numbers, how much it's affecting everyone. But in the state of Connecticut in 2015, 855 people died because of an opioid abuse, and 25% of those were from prescription opioid abuse. I have charts and tables that I show when I do this presentation locally, how it affects each and every community. 30 people in the last 6 months died in the city of Hartford because of opioid abuse. So I want to bring this crisis home. It is not just heroin, not just illegal fentanyl, it is opioid prescription misuse. So prior to EPCS, the workflow for prescribing Schedule 2s, 3s, 4s, and 5s was very disjointed. In Connecticut, we were allowed to prescribe 3s, 4s, and 5s using our electronic EHR, but the prescriptions were dropped to fax. So the provider thought it was an electronic prescription, but in actuality, it generated a fax that went to the pharmacy. For the Schedule 2 medications, the state would not accept a fax electronic signature form, so the providers had to print out the Schedule II, sign it with a wet signature, then fax it over. The state would accept that. It made no sense. It was a dual workflow, which was very frustrating and a time waster. Whenever you have the patient prescriptions floating around, there's always the risk. In Connecticut, we need to have our license number and our DEA number printed on the prescription. So when you hand that prescription to the patient for Percocet, your DEA and license are right on there. There's the risk of fraud, forgery, changing prescriptions, or stealing prescription pads. Forging provider signature is not difficult. So there was an issue here. We originally thought about going to EPCS when we started going live, but it just seemed to be too much all at once to change all these workflows, so we put it on the back burner. Until last June. On June 30th last year, the governor signed a bill mandating the use of EPCS in Connecticut. Everyone had to do it anytime you were prescribing from a hospital or from a practice to an external retail pharmacy. Does not count for inpatient pharmacies, but anything outpatient needed to go via EPCS. And they gave us 6 months to do it. We had to have this up and running by January 1 of 2018. Not a lot of time. We had to meet all of the state DPH requirements and the federal DEA requirements, so it was a big lift. What we're going to talk about now is how we did it. We developed a search committee that looked at 3 different vendors who provide EPCS services. We already had Access One, which is a single sign-on with Imprivata. So we looked at them and 2 others. The search committee was made up of my CMIO council, which is our regional CMIOs and director of documentations. We had our IT leads, our technology leads, implementation leads, and a project director. We also developed a panel of subject matter experts. I originally invited 32 providers, both physicians and advanced practitioners. We ended up having 18 who attended. And these were from throughout the state, providers, APRNs, PAs, from all hospital, clinic, and ED departments. So we had a really good representation. And they helped determine which methods we were going to use in the provider-facing functions to help us get buy-in. After looking at the different vendors, we decided to go through Imprivata because they had solutions which fit our needs very well. The workflows looked very clean, and it was tightly integrated with Epic, single platform, and we had this existing relationship. We knew how to work with them. We had developed a rapport and a trust with them, and we knew they were committed to help us succeed. Now we had to look at the workflows. The DEA and the feds require a 2-factor authentication, meaning you need to have 2 of those 3 categories in the picture. Something you are, either fingerprint, palm print, retinal scan, voice print. Something you have, which is a token, either a hard token or a soft token. And something you know, which is your password and login information. And you need 2 of those 3 in order to electronically prescribe according to the federal regulations. Smartphone can be used in a few different ways. It works very well because almost everyone has one, although we still have some people still on flip phones who refuse to change. It's a very simple workflow to do 2-factor authentication. It works with EPCS when you're off the grid, when you're using it on your laptop out camping someplace. You don't have to have Bluetooth with it. You don't have to have Wi-Fi or cellular signal. You have to have any one of them. It works very well, and it does sync with the iWatch for Apple users. The con is it is a personal device, and some providers don't like using personal devices for work-related activities. The other issue with phones is if you lose your phone, buy a new phone, you do have to re-enroll. It's not just as simple as downloading the app. You have to go and re-authenticate, which we'll get into in a minute. Another option is the hardware. This is a key fob, which is basically a small item that is a random number generator that puts out a number that you have to key in to your EHR in order to sync them up. It's an inefficient workflow because it does have to be entered, and it's easily lost, and it's left on your dresser at night, and not as convenient as the phone, which you always have with you and carry with you. The third option is biometric fingerprints. It works very well. It's simple to use. You can register your whole hand or both hands with the fingers, and it works if you don't have your phone or your hardware key fob with you. The con is you have to buy it. It's expensive. I know when we were purchasing them, they were running about $140, $150 a piece. Another issue is we use Workstation on Wheels. We have our single sign-on badge tap, and there's limited desktop space both on the workstation and limited USB ports on the computers. So that is something you have to think of. And enrollment considerations, again, you have to register everyone's finger to do it. Not a big deal because it can be done at the same time as you register them with the phone or the key fob. So we decided to use the smartphone app with a push token and fingerprint readers in limited areas, emergency departments, ambulatory surgery, where you were in one place doing lots of activity. The smartphone app can be used in a couple of different ways. You go into your EHR, you put in your prescription, you enter your password, and within microseconds, you get a pop-up on your phone saying, "Did you approve this request?" You swipe on it, you say approve or deny, and you're done. It's very, very fast. Same thing happens on the iWatch. You get the similar screen. Do you approve, yes or no? If you're not hooked up to the Bluetooth or the Wi-Fi, the same thing. It works over your cellular network. If neither of them work, it works as the random number generator that the key fob did. So you put in your prescription, you will get this space that says enter the 6 digits. You look on your phone, click open up the app, and you get the 6 digits and you enter it. So it's a good backup if you're out of signal. Works very well. The fourth step is credentialing. That's the biggest step. We decided to do what's called institutional identity proofing. We're going to take the responsibility to do it to our own people. The DEA requires an in-person ID check of all providers. You have to go to them or they have to come to you, look at them face-to-face, check their credentials. We decided to use a government ID and your hospital credential. So it needs to be a passport, a driver's license, something like that, and your work credential, which has the picture on it. Imprivata has a very nice workflow that they share with you to help go through this. We use both internal and external people to do this. We had a lot of people on some of our registrars, our departmental administrative people, medical staff office people. We also hired some contractors to help us fill the bill. We now have people all over the system. We probably have over 150 people who could register you for EPCS. So you're never more than a couple of miles away from somebody. It makes it very easy to do. Step 5 is logical access control. The DEA mandates someone else has to enter you into Epic or into your EHR after you've been credentialed through your EPCS vendor. It takes 2 separate individuals to do this. One has to grant the permissions, and then one has to authenticate that the person who's doing it and the information they're entering is authentic. So it really takes 3 people to do this. So logical access control can be done in the office. It does not have to be done when you're rolling out the single sign-on information to the providers. Next step was go live. Something I didn't talk about at the beginning when I said the state gave us 6 months to plan this out. Well, they did not know at the time that we had a double upgrade in July of 2017, 2 versions of Epic upgrade, and we had our 5th hospital go live in October. So we were a little busy at the time. We really had about 4 to 6 weeks to do this whole thing. At the time, we had about 4,000 providers in our hospitals and behavioral health centers, 150 sites. We generated a report from Epic identifying who our prescribers were. And we said if you prescribed more than one controlled prescription per week, we were going to focus in on you. We sent direct email, division, department emails, posters, newsletters, meeting announcements, telling everyone this is coming, be ready for it. Starting in beginning of December, we set up multiple sites for enrollment. We had kiosks in the cafeteria and the doctor's lounge, the surgical lounge. We went to certain of the big offices. We went to a lot of the department meetings. So the med staff meeting, we set up our table with a couple of laptops and our fingerprint scanner out there to register people. Registration takes about 5 minutes or less per provider, and we use that time to give them the information and the instruction on how to use it. It's a very simple system to use, one tip sheet that we handed out. You need a great project manager and a great build team to make sure all your security templates, med groups are built correctly. This was all hands on deck for a few weeks, and it went very, very well. When I made this slide after the first 2 weeks, we've noticed increased provider workflow. Providers are happy and patients are happy. I'll get into the patients in a minute. It's very secure. There's no paper prescriptions floating around. The chance of fraud or forgery is very, very much decreased. We also noted that with the patients, usually you don't want to prescribe a lot of pills for a patient for an acute pain. So you would prescribe 10 days, 2 weeks, and the patient would have to come back and get additional prescriptions if the pain continued. With EPCS, since it's so simple, you can give them 4 or 5 days worth. They can call you or message you. You can refill that prescription electronically right to the pharmacy without them having to come into the office to pick up a second or third paper prescription. So patients really like this system. As you can see at the bottom, on day 1, January 1st of this year, we had a 73.5% compliance rate. By day 4, we were over 90.5%. By day 7, 92. By day 40, 94.39. And as of this morning, in the 48 hours that ended at midnight last night, we were at 97.46 compliance rate. We never expect to get to 100 for a few reasons. Number one, compound medications with significantly complicated SIGs, things like that, are not prescribed via EPCS. Out-of-country prescriptions. We have patients going to Canada, cannot be prescribed by EPCS, and we still have those few Luddites hanging out who refuse to get rid of their flip phones and want to keep and they don't want to go to Apple, so we don't expect them to come on board. But for the most part, 95, 96, 97% is an excellent response, and we're very pleased on the way this is working. Tips for success: don't do what we did. Start as early as you can. We had to do it in a couple of weeks. We did it, but there's easier ways. Involve your providers. Get them to help you decide which methods you're going to use, which hardware you're going to use, which software you're going to use, and your rollout message. The more you can get your providers to buy in, the more they can help share the information. Identify and target your heavy providers. We did not limit this to the 2,000 that we identified. If someone else wanted to register, fine, we did it. But we went after our group to prescribe more than once per week. Have lots of registrars, have them available, and publish who they are, where they are, and how to get in touch with them. We also enrolled everyone for fingerprints, even though fingerprints were not being used in all locations. Eventually, we're going to go to fingerprints once we have the bandwidth to do that, so might as well have them registered at the same time. We also registered people for single sign-on at the same time. If they're new to the practice, if they're onboarding, we register everyone for everything at the same time so they don't have to come back. As I mentioned, training is very quick. Do it during registration, give tip sheets. It did not require any classroom or recorded webinars or anything. It was very simple and easy to do. And now I'm going to pass on to Dan, who's going to talk more about Imprivata.
Great. Thank you, Dr. Ehrman, for that great overview of how you were able to achieve EPCS success in such a short period of time. So now what I'll do is I'll quickly talk about Imprivata Confirm ID, which is our solution for EPCS and the one that Dr. Ehrman at Hartford Healthcare is using to meet the DEA compliance requirements, as well as give his users that fast, efficient workflow. So as Dr. Ehrman mentioned, when it comes to EPCS, there are a number of unique and specific requirements that you must meet per the DEA in order to comply. The DEA wants to establish what they call non-repudiation with absolute certainty, that this entire process is completely secure from provider all the way through to the patient and to the pharmacy. So we often talk about a secure, auditable chain of trust that needs to be in place, and that includes things like ensuring the identity of each provider who's going to be doing EPCS, binding their identity to the two-factor authentication credential that will be used when prescribing controlled meds electronically, initiating a logical access control to give your providers permissions in your EHR or your e-prescribing application, including that second individual who needs to approve that step, a complete set of two-factor authentication credentials that will meet the DEA requirements, and then all of the reporting that kind of goes along with that. So there are specific requirements in each of these steps that you need to meet in order to comply with the federal rule, the DEA rule for EPCS. And as you can see here, Imprivata Confirm ID is designed to help you do just that. It's a complete end-to-end solution for identity proofing, supervised enrollment of the provider's credentials, logical access control, including the EPCS access approver role, a set of flexible authentication options, and then all of the reporting that goes along with that. So with Confirm ID in place, you can meet all of the DEA requirements for EPCS and then also deliver a two-factor authentication workflow that's very fast and easy for your providers. So a couple of specific features of Confirm ID. One is around the identity proofing. So as Dr. Ehrman mentioned, before you can enable EPCS, you actually have to go out and check a photo-issued government ID at a minimum of all of your providers and keep a record of that. That's a requirement for the DEA. And you must do that even if the providers are already credentialed and prescribing controlled substances on paper today at your organization. You must do it again specifically for EPCS. And Confirm ID gives you a tool as part of the system where you can assign enrollment supervisors or witnesses who will actually be assigned to go out and check the identity. And you can see here what the screen will look like. That provider can check off the driver's license or whatever other forms of identification you'll require by your policy, and that supervised enroller will authenticate, and that will capture a record of that identity proofing process taking place. Immediately thereafter, the provider can then enroll whatever modalities, whatever credentials they'll use for EPCS. In this case, they're enrolling a fingerprint. They could also enroll their phone if they'll use that for a token, as well as a hardware token. And as part of this workflow, the provider will enroll, again, in the presence of a witness, who will then authenticate to capture that this provider who just completed the identity proofing process has now their identity bound to those credentials that will be used for EPCS. No security gaps, nice, secure, auditable chain of trust. And the other thing that will do is by having your providers enroll their credentials in a supervised way, it makes sure they do it correctly the first time and they do it quickly, and that really gets them off to a good positive experience with EPCS. So a second feature of Confirm ID, as I mentioned, is the EPCS Access Approver, which is part of the logical access control requirement for EPCS. So the DEA says that in parallel to the identity proofing, a separate group within your organization needs to actually configure your EHR or your e-prescribing application to give approved providers permissions to do the EPCS workflow. Now, that has to be approved by a second individual or a second set of individuals known as EPCS access approvers who will go in and validate that, yes, the EPCS permissions were given to this approved list of providers. In Confirm ID, you can assign that role of EPCS access approver, and those individuals will get a notification that they need to go in and approve these providers, and they'll authenticate using Confirm ID, and that will capture a record that this piece of the process took place. So now you have an audit record, as the DEA wants to see, that you did meet this requirement for the logical access controls piece. Now, from a workflow perspective, as I mentioned, Imprivata and Confirm ID really want to make it as easy as possible for your providers to complete that two-factor authentication at the time of prescribing that's required per the DEA, especially in a case like Connecticut or other states where it might be mandated and paper is no longer a backup option if the provider doesn't have one of their credentials. We want to be able to give you all of these different options so that you have that redundancy and flexibility. And so Confirm ID supports this broad range of DEA-approved authentication modalities for EPCS. At the time of prescribing, providers must enter a combination of the two of the following three, as Dr. Ehrman discussed. Something they are, such as biometrics, something they have, which is most often a token, and something they know, which is usually their password. Two of those three at the time of prescribing. Confirm ID supports all of these different modalities. We support fingerprint biometrics. We also support tokens, and that can be delivered in a variety of different ways. Something we call hands-free authentication, which I'll discuss in a moment, a push notification, which I'll also go through, as well as conventional software and hardware tokens. And the idea is that we can give you all of these different options for your providers to mix and match in any combination you need to give providers that flexibility to meet all workflow scenarios, as well as redundancy. For example, if a provider doesn't have their phone, they could fall back on fingerprint plus password. Importantly, the product will only present your providers with whatever modalities they have available to them at that time, and it will always default to the most convenient set of options. So that, again, in any given prescribing scenario, whether it's in the hospital or at home or some other remote location, that provider will only be able to use whatever is available to them at that time, which will make the process as easy and fast and seamless as possible for them. So a couple of modalities I'd like to just go over quickly are hands-free authentication, which I mentioned previously. Now, this is a technology that's unique to Imprivata, and it completes the second factor of authentication automatically without the provider having to do anything. So the provider will enter the EPCS order, and they'll complete the first factor of authentication, which in this example is a fingerprint biometric, but it could be a password if you're not using fingerprints. Hands-free authentication will then automatically retrieve that token code that's running on the provider's mobile phone, an app on their mobile phone, and it will authenticate them. They don't have to take their phone out of their pocket, unlock it, and open up the app, enter that 6-digit code. They don't have to do anything, completely hands-free. So effectively, in this scenario, they can complete that two factors of authentication simply by putting their fingerprint down. And this is something that really drives efficiency, and we see in use in high-volume areas such as the ED or certain departments such as orthopedics or discharge stations where efficiency is really something you're after, especially given the volume of prescriptions that are happening. Now, second option with that token that Dr. Ehrman mentioned that Hartford Healthcare is using is the push token notification. So this uses the same token application that's running on the provider's phone, but instead of being completely hands-free, the provider does have to approve that notification on their phone. You can see, though, that it is fast and easy. The provider will enter their first factor of authentication, and then Confirm ID will send a notification to their mobile phone. And right from the lock screen, they can simply press approve, and they'll be authenticated. Again, eliminating the need to unlock the phone, open up the token application, and then enter over that 6-digit code. And so this is really a great option, password plus push, to be able to do EPCS anywhere because it doesn't have the hardware requirements associated with fingerprint biometrics or the hands-free authentication. And this, again, is a really great option to give your providers as not only a backup when they're in the hospital, but as an easy way to do EPCS from home or another remote location. And so finally, Confirm ID also is going to help you meet, as I mentioned, all of the different EPCS requirements per the DEA including comprehensive reporting and auditing. So the DEA has a number of different reporting requirements throughout all of the different steps that we've been discussing and more. And ConfirmID is built with all of those different reports you need so that in an event of an audit, you can easily show that non-repudiation, that secure chain of trust that the DEA is looking for. And together with the reports that your EHR will be able to generate, ConfirmID plus the EHR reports will give you that comprehensive audit record of meeting all of the compliance requirements for EPCS. And so finally, we've been talking about EPCS, and ConfirmID is that end-to-end solution, but the product also offers a number of different workflows because we know that increasingly your organizations are wanting to use two-factor or multi-factor authentication for more workflows than just EPCS. And so ConfirmID really is a complete multi-factor authentication platform designed specifically for healthcare. So in addition to EPCS, the product enables second-factor authentication for remote network access through your VPN, access to cloud applications, access to Windows servers for your IT admins. There are also a number of other clinical workflows within your EMR that may require a re-authentication that ConfirmID can handle. And we're also enabling authentication to medical devices as part of the complete platform. So the idea is to give you the ability to set all of your authentication policies from a central location, which will hopefully reduce your total cost of ownership, streamline reporting, and make it much easier on your users who will be required to have a single, familiar, fast authentication experience. And really that'll give them more time to be spending with their patients and focused on patient care and kind of less on the technology. So that's a little bit more about ConfirmID. With that, I'll now turn it back over to Elizabeth.
Thanks, Dan. So we're now going to move into the question and answer portion of the webcast. As a reminder, audience members can submit questions using the question tool to the left of their screen. This first question is going to go to Dr. Ehrman. Who at Hartford Healthcare serves the role of EPCS access approver to approve the EPCS permissions in Epic?
Again, the approval is based on your license. If you are a licensed prescriber and have a DEA number, the registrar, they will already have access in our EHR. So the registrar just verifies that by looking up the patient and see if this person already has an active prescribing credentials. And if that's already in there, then we use that as our verification. I'm not sure if I answered that question to your satisfaction.
Sure. I actually have a follow-up. When choosing registrars, are there special considerations? What kinds of administrative groups make good registrars?
Someone with administrative responsibilities, someone who is available to the providers in many different locations at many different hours during the day. And we're assuming that people who work in your medical staff offices or work with EHR are trustworthy. Because again, it's a federal requirement to do this, and if there is anything untoward going on, someone's going to be held responsible for it. So we do not identify anyone, we do not do any background checks because they're working for us, we know them, so we trust them.
Our next question is for Dan. Dan, can you provide more detail about how hands-free authentication works?
Sure, my pleasure. So hands-free authentication uses Bluetooth technology and specifically Bluetooth low energy. And it requires a couple of things. One is the Imprivata ID token app that's running on the provider's phone, and that looks like any token application generating a random number every 30 seconds. So that app needs to be on the provider's mobile phone. And on the endpoint, there does need to be a Bluetooth receiver. It's just a small USB receiver that is used exclusively by Imprivata for Bluetooth, for hands-free authentication. And because it is a second factor of authentication, when it's invoked, hands-free authentication is only looking for that specific provider's phone. So often we'll get the question, if there are multiple providers in vicinity that all have this technology, how does Confirm ID know to look for that individual prescriber's phone? And again, it's only looking for that provider's phone because it already knows who it should be looking for, because it's the second factor of authentication. And further, your provider is already logged in to the EHR. The second bit is, because it's Bluetooth low energy, there's no pairing required. So it will just automatically work. There's no pairing either initially or at any point throughout the entire process. So it's through Bluetooth, and again, the app on the phone. If for whatever reason you have this enabled but it isn't working, maybe the provider doesn't have Bluetooth turned on their phone, the product will recognize that. It will ask them to turn it on. If they don't, or if for whatever reason it isn't working, then it will default to that push token. It will send them a notification to that phone, and they'll just press approve on there.
Great. Dr. Ehrman, how do you handle mid-level or residents who do not have their own DEA number?
Residents in Connecticut, advanced practitioners do have their own DEA numbers, but if they work for the institution, then they use the institutional DEA number, just like they would do when they're writing paper prescriptions. We do work with UConn Medical School, and their residents all use the UConn DEA, and that's what we work with.
It was mentioned earlier in the presentation that two separate individuals need to authenticate others. How did the first person get signed off?
I'm not quite clear what the question is, but you need someone to enter the information and grant the security in Epic, then someone else to make sure it was done appropriately. That's the bottom line. It's just a double check mechanism.
Yeah, so that's the logical access control piece and the role of EPCS access approver. You know, once you have your approved list of providers through the nomination process, that will go off to the EHR team. In Dr. Ehrman's case, the Epic team, but whoever would be granting the permissions in your EHR for EPCS, they will configure it for the list of physicians on that list, and then before they can be enabled, before it can go live, that needs to be approved by that second individual Dr. Ehrman mentioned. That's that EPCS access approver role.
Dan, as a follow-up to that, how can one make sure that users have access to only need-to-know data, and how do you know when they are trying to grant access to off-limit files? Just to say that again, Dan, how can one make sure that users only have access to need-to-know data, and how can a person know when access to off-limit files is being asked for?
I guess I'm not really understanding the question in the context of EPCS.
Yeah, I agree. That's not really an EPCS question. The only thing they're doing here is taking the same functionality within their EHR and prescribing using a different method. So whatever files they have access to through their EHR security doesn't change.
Okay. Dr. Ehrman, I have one more question for you. What happens if a pharmacy does not have the medication in stock?
Pretty much the same thing that would happen if it was a paper prescription. It would either be denied, canceled. The pharmacy would contact the provider to send it to another pharmacy. The workflow really doesn't change a whole lot. The only thing that changes is the patient does not have a piece of paper to carry to the pharmacy. But if your pharmacy doesn't, keep things in stock, sometimes they'll get it transferred over. Sometimes they'll send the patient to another pharmacy. Then they will have to contact the provider to reissue a new prescription via EPCS. And that does happen. One thing I forgot to mention when talking about this is EPCS, although it is legislatively mandated, there are exceptions and exemptions from the rule. For example, if there's a power failure, if your EHR is working, you can print out the prescription and put the notation on there that there was a power failure. Now, at least in Connecticut, they do keep track of those exceptions, and if it seems like the same person is applying all the time, it will raise some eyebrows. But you know, if your EHR is down, you can still print out a prescription or write one out by hand.
Dan, if a provider gets a new phone, do they need to enroll it through supervised enrollment again?
That is a good question. So the DEA says that before a provider can use a two-factor authentication credential, a phone, a fingerprint, you must check their government-issued ID. And so that's what happens at the onset of the EPCS project. But if a provider loses their phone, then and gets a new one and needs to enable that for EPCS, you've got to have a way of binding the identity of that provider to that new credential. So the DEA does say you need to go out and check that provider's ID again before you can bind that specific credential to them. However, in Confirm ID, there is a way to do it through heightened self-enrollment, we call it, that does not require supervised enrollment. So long as the provider has at least one authentication method enrolled in a supervised way, they can use that method to enroll a new phone. So this is why it's really important. Another reason it's really important that we recommend having fingerprints enrolled, even if you're not necessarily going to use fingerprint biometrics at scale. It's good to have that backup in certain places, but it's also good to have for that self-enrollment. So in that case, if a provider gets a new phone, they can use password plus fingerprint biometric to authenticate and self-enroll their phone for EPCS. Otherwise, yes, they would have to go through supervised enrollment again.
Great. So that concludes today's healthitsecurity.com presentation. Special thanks to our speakers, our audience, and our sponsor, Imprivata. Thank you for joining us today, and goodbye.